living long for a long time with conditions, chronic conditions that and actually dying from those current conditions that are usually found in older age white Americans. And these diseases basically, they start early, they can cause death also earlier, and also they can cause dysfunction and disabilities, and also they are basically silent killers, these chronic conditions, because they are not diagnosed for many years. And health differences are often due to economic and social conditions, the differences that are more common among African American than whites. I put this slide, basically this is from CDC back in 2017. If you look at different kind of disease that we are talking about, like hypertension and high blood pressure, diabetes and a stroke, they divided based on 3 different ages groups: 18 to 34, 35 to 49, and also 50 to 64. You can see in all those age groups the percentage of African Americans is significantly higher than white people. And in the lower portion of the slide, you can see that African Americans are more likely to die from early ages from all causes. So that's basically all causes mortality in different age groups, those 3 age groups. For example, in age 50 to 64, you can see the huge difference, 1046 compared to 722 deaths per 100,000 people. The other item that I collected from CDC information is African American ages 18 to 49 are 2 times more likely to die from heart disease than white. African American ages 35 to 64 are 50% more likely to have high blood pressure than white. African American women are 40% more likely to die from breast cancer, and African American male are 1.3 times more likely to have new cases of colorectal cancer, and 20% more African American, 20% more likely to have psychosocial stress or distress, and also 50% less likely to receive counseling and mental health treatment. So you can see there is a huge gap there between African American and white. So what are the, I basically prepared also a slide on the social factor and health risk affect, basically that affect African American in younger age. If you look at different topics like unemployment, living in poverty, not having home ownership, not being able to see your medical doctor, also smoking, not being active, and also obesity, you can see that all of them basically African American are in worse condition than white, in sometimes very significantly. So we talked about the problem. So what can be done and what has been done, which is not complete, but these are the topics that has been addressed in this regard. So the federal government is basically collecting data to monitor and track health conditions that may affect health, such as poverty and high school graduation, through Healthy People 2020. That's the project that they are doing. Also, they are supporting partnership between scientific research and community members to address disease and conditions that affect some population more than others, like those conditions that we discussed. Also, they are addressing heart disease, stroke, and other cardiovascular disease, which disproportionately affect African American, by implementing different national initiatives such as Million Hearts. They're also supporting actions to create healthy food environment and increase physical activity in underserved community. Also, public health professionals, they can use proven programs to reduce disparity and barriers to create opportunity for health. Work with other sectors such as faith and community organization, education, business, transportation, and housing to create social and economic conditions that promotes health starting in childhood. And also they can link people to doctors, nurses, and community centers to get medical care and also follow-ups. They can also provide and develop training for healthcare professionals to understand cultural differences in how patients interact with providers and healthcare system, different healthcare systems. And also in community organization, what they are doing, basically, they can train healthcare workers in underserved communities to educate and link people to free or low-cost healthcare. They can conduct effective health promotion program in community like work, school, and also home setting. They can work across sectors to connect people with services that impact health, such as transportation and housing. And also they help people see doctors, take medication as prescribed, and get follow-ups appointments. Healthcare providers also, they can also do work with communities and healthcare professional and professional organization to eliminate cultural barriers to care. They can connect patients to community resources that can help people remember taking the medication and get prescription refilled and get the follow-up visit. They can learn about social economic conditions that basically causes those disparities and put some people in higher risk. They can collaborate with primary care physicians to create comprehensive and coordinated care, which is basically approach to basically patient care approach, and promote a trusting relationship and by encouraging patient to ask questions. So I didn't want to finish on all bad notes. You can see in this slide that since there have been some improvement, the leading causes of this for African American have decreased from 1999 to 2015. If you look at 3 major causes of this, which is heart disease, cancer, and stroke. In heart disease, African American mortality from heart disease actually 43% decrease compared to 38% in white. So basically, the African American community had more reduction, but we need to remember that they started in a higher level. The same for cancer, and the stroke is both communities, but both races actually they reduce 41%. I tried to make it short so we can have some time to discuss any question if anybody has a question.
So Dr. Teimoori, we're going to do the Q&A at the very end.
Okay.
And we thank you.
No problem.
Thank you. So up next is Dr., and tell me if I'm saying it correctly, Olusola. Am I saying it correct? So Dr. Olusola has worked for Tri-City for many years. He's an MD, having more than 35 years of diverse experiences, especially in psychiatry. He works in the adult outpatient clinic at Tri-City Mental Health Authority. Please welcome Dr. Olusola.
Okay.
We can have Dr. Lipscomb start, and maybe Dr. O, you can look for it.
Okay, why don't you go ahead and do that?
Yep. Are you okay, Dr. Lipscomb?
Actually, Veronica is going to introduce Dr. Lipscomb.
Okay.
Veronica, can you please do the introduction?
Yes, absolutely. Can everyone hear me? I'm off of mute, right? Okay. So Alan Eugene Lipscomb, Associated Professor in the Social Work Department at Cal State University Northridge. Dr. Lipscomb is a clinical psychologist by highest degree obtained. He is a licensed clinical social worker in the state of California. Dr. Lipscomb received his doctorate in psychology with a clinical emphasis in marriage, family, and child psychotherapy from Ryokan College, and his master's of social work from the University of Southern California. In addition, Dr. Lipscomb studied diversity and inclusion practices within organizations through Cornell University, earning a certification from the School of Industrial and Labor Relations at Cornell. Dr. Lipscomb specializes in providing anti-oppressive and inclusive mental health services to individuals, children, youth, and families of color. Thank you, Dr. Lipscomb, for can you unmute? Yeah, thank you.
Yeah, thank
joining
you.
us today. Welcome.
Thank you so much, Veronica. So I have a few slides that I'm going to go ahead and share my screen with you all. Can everyone see that? You can just put your thumbs up for me.
Yes, we can.
Thank you, Chris. So I'm going to specifically talk about mental health, healing, well-being as it relates to therapy and psychotherapy for Black folk. So some of the current mental health challenges that we are seeing, or that I am seeing in practice settings, especially this year, is depression. Depression, of course, related to COVID, related to the changes as it relates to what is happening, but also depression as it relates to race-based trauma, which I'm going to talk about in a moment, and race-related issues that we've seen come to the forefront. You know, it's always been there, but it has come to the forefront this year, and needing to address it, right? And needing to do something about it. What I'm also seeing in practice settings is anxiety. Anxiety related to what I just touched on, but also anxiety related to still needing to stay afloat, still needing to ensure that needs are being met within your family system or within the communities for those that are working with the community. And then also PTSD, right? So seeing a lot of PTSD, race-related fatigueness, which relates to the race-based trauma that is being experienced that I'm hearing about in practice settings, related to microaggressions. You know, one of the things we've seen over the past year is this outward expression of spewing hate, if you will, towards people of color, specifically talking about Black folks or those who identify as Black African American. So these are some of the things that I am seeing play out, and it's from as young as 18 that I'm seeing in my practice, and then it runs all the way up in the age. So what is needed when accessing and providing mental health services is to have a trusting relationship with the provider, and for the provider to be intentional, because like Dr. T was talking about in his intro, there is a lot of stigma, there is a lot of shame associated with accessing mental health. And if I access mental health, what does this mean for me? What does this say about me? Does this mean that I'm crazy, etc.? But one of the things that I have found in my practice is that Black folk, African American folk are wanting the services. They're wanting to get the support and wanting to access it. So if and when they are coming in, how are we as service providers providing that trusting relationship and building that? And this comes from the consistency in how we as therapists are showing up in sessions, how we're moving in those sessions, what we are saying, what we're not saying as it relates to the larger socio-cultural climate that's happening outside of the sessions. You know, gone are the days where we don't talk about what is happening at the meso kind of macro level as it relates to politics, as it relates to the pandemic, right? That's part of what we're having to be intentional in talking about, especially related to race and racism. And then also being intentional about collaborating with them, being aware of that power dynamic as someone who is the provider, the therapist, working with them and joining with them, co-creating this wellness and well-being and healing with them, and not being the lead as the provider, but really joining and working with them. Also examining intersectionality. And for those of you who are not familiar with intersectionality, not only does it look at your identities as it relates to gender, race, gender identification, sexual orientation, etc., but also it looks at privilege and oppression, and based on your intersecting identities, how that then relates to the structures of oppression in our society. And so one of the things I'm being intentional about in working with African American and Black folk is talking about how they're experiencing work or lack of work, how they're experiencing their community based on who they are intersectionally speaking, and based on larger structures and systems that are oppressive. And then also being intentional about taking anti-racist practices in my clinical interventions and how I'm showing up with Black folk becomes important. Naming racism, naming microaggressions is a affirming experience. It's a validation experience. Far too often, the folks that I work with come into services and no one has ever named it and said it out loud. So when I say it and attach a name to it, that is also reassuring for them and in letting them know that they're not the one going quote unquote crazy, that this is not them making this up, but this is happening to them. And so how do they move through different systems, different environments based on the racist practices that they're seeing? And then also being intentional about my own social location and positionality as it relates to power and privilege and providing services and being a provider. So I talk about how is it for you working with me? How is it for you working with me via Zoom? I'm doing all virtual sessions at this time. I'm not seeing folks in person. And so talking about what it's like to sit virtually across from me, what it's like to be sharing some of this more intimate stuff that you've never shared with anyone. What is it like for you sharing with me as a Black man, even though you are a Black person that I'm working with, still talking about that, because recognizing that we as Black folk are not a monolithic group and there is diversity within it. And also recognizing that I could represent someone who has traumatized you as well, based on your past experiences. So that becomes important too. So I want to wrap up with several types of therapies and approaches and things to consider when working with Black folk in therapy. One is narrative therapy. And this is where we seek to externalize the problem, that they in and of themselves are not the problem. Society, larger systems of oppression, that's the problem, and it impacts their mood and how they're moving based on what is happening, especially now in 2020. Another thing that I am doing is known as generative somatics. So generative somatics taps into not only who the person is and their innate assets and strengths and resiliency factors, but also the legacies, right? Connecting integrated healing, mind, body, and spirit to really strengthen and helping them navigate injustices within the communities, within societies. So providing them the tools and resources to continue to do the fight, to continue to move forward, but also gain strength from that to combat these systems of oppression in their day-to-day. And then again, practices that seek to honor legacies of strength and resiliency within the African-American Black community. So tapping into those narratives that are affirming, that are true within their family system, and also historically tapping into that. So incorporating CRT tenets becomes important, counter storytelling. Also Black feminist approach, right? Tapping into Black women who have been very intentional about fighting oppressive systems within our society and culture as well. So these are some of the things that I am seeing and noticing and utilizing in today's climate related to African-American folks in mental health and well-being. I'm gonna go ahead and stop sharing.
What I decided, okay, see, can you hear me? All
Yes,
right.
we can. Yes, we can.
So, I'm going to break it into two short presentations. My first presentation is in line with this last presentation. I want to share my personal experience as a man of color here in the United States, as a man who has lived in other countries. I grew up in England. I went to England in 1968. I did my elementary, high school, and first year of college. Went to Nigeria, did medical school, went to the Caribbean, practiced, and came to the United States. Now, I came to the United States. I really didn't know a whole lot about America, okay? I was invited here by American students that I used to take care of overseas. Nothing in my past could have prepared me for what I encountered. I did my boards, applied, was accepted for pediatrics at Penn State University. Predominantly Caucasians. I was the only Black person in the department. I was introduced to my senior who was going to be in charge of me. So he pulls me into his office and he looks at me straight in the eye and he says, "We don't usually allow Black folks to graduate from our program." Now that just kind of struck me. That struck me because I never experienced that. I never experienced that in my life. But somehow I brushed it aside. I smiled, but he obviously was not smiling. Now this was what, 1980, this was 1989. As time went on, I was assigned to a cancer unit in Hershey, Pennsylvania. That's where this all took place. And I noticed that I was being kind of picked on, very, you just can't do anything right, okay? One of the things that happened to me is, now, remember now, I was practicing before I came to the United States, so I had a lot of experience. In fact, my first job was in neurosurgery. I was practicing in neurosurgery, doing back surgery, doing head surgery in the Caribbean. That was my first job. I was doing deliveries, so I had a lot of experience. The Dr. Sweeney, who was my supervisor, instructed me to give chlorohydrate, 1,000 milligrams of chlorohydrate, to a 10-year-old girl who had stage 4 cancer. We were sending this child to the radiology department. And I looked at him, I said, "Dr. Sweeney, that's too much." Well, he looked at me, he said, "No, you do exactly what I tell you, otherwise I'm going to report you." I said, "I'm sorry, I didn't mean to upset you." And the nurse was standing right there. When he left, I knew in my heart that that child could not, there's no way this frail child could tolerate 1,000 milligrams of chlorohydrate. So I gave the child 250 milligrams. And I went to join the department meeting and I sat in the back. Now, Dr. Sweeney was paid out of that conference. I didn't know why he was paid. I later on learned why he was paid. He came back into the conference and he's pointing his finger at me like, "You are in trouble." He sat down. 7-10 minutes after he sat down, code blue. Pediatric, code blue. Radiology department. Everybody just took off running down the step, jumping down the step. The 10-year-old girl coded. It took us 2 hours to resuscitate that child. All of a sudden, Dr. Sweeney calls a conference with all the heads of departments, psychology, surgical, and they put me in this room. Remember now, I'm the only Black person in the department. And he's pounding the table. "This man's got to go. This man has got to go. He's a dangerous doctor." And they put me in this room, and I'm thinking to myself, I spent my whole life trying to be a doctor. My mother worked 2 jobs. My father worked 2 jobs. They got me and my brother through medical school. And the lawyer looks at me, he goes, well, you know what? You're so dangerous, because that's your patient. And I'm thinking, oh my goodness. I had tears just pouring down my eyes. This conference took about 15 minutes. They said, well, you're a bad doctor. And you know what? They stood up, and as they walked away, I said to myself, can I see the chart? Because they wouldn't let me see the chart. I said, can I see the chart just one time before you take away my license? And I took the chart and I opened it. Dr. Sweeney had, when he left the conference, he had canceled out my order and ordered the 1,000 milligram, which is 4 times what I ordered. And he sat on that panel pounding for me to lose my license. You understand what I'm saying? So I said to the lawyer, I said, excuse me, everybody, can everybody just give me one? I said, look at the chart. He wrote it. And you know what? Not a person complained. Oh, Joe, you wrote it. They walked out of that room smiling, case closed. I sat in that room by myself, shaking, sobbing, nobody to comfort me. The head of the Department of Psychology, after everybody left, she kind of turned around because she didn't want anybody to see her. And she came and looked at me. She said, I am so sorry for the way they're treating me. He said, but I'm not racist. I get it. I said, but I can't do anything about it. And she walks away. I became fearful. I developed anxiety. Every time I would write a prescription, I'm on my way home, I would turn around to make sure nobody changed it. I mean, it was driving me crazy. Well, fortunately for me, I was getting ready I had to do my next rotation out of Hershey. I had to go to the General Hospital in Pennsylvania, in Harrisburg, Pennsylvania. So the gentleman who was head of he's from India. The consultant there is a guy from India, Dr. Verma. And so we get there, I would start working, and a lot of children were being brought in, required certain procedures like lumbar punctures. Well, you know what? I can do lumbar punctures with my eyes closed because I'm experienced. I was doing neurosurgery. So I did not know that people were paying attention. I would do 3, 4 lumbar punctures in a single day, 5, 6. I was the only first-year resident who was capable of doing a lumbar puncture. I could do exchange blood transfusion. Nobody else could. And I was just getting close to the end of my rotation, my 4 weeks rotation there. We were to return back to the main hospital. Dr. Verma calls me, he said, come. He said, come to my office. And he locks the door. He said, shh, I don't want you to say anything. He said, I'm going to tell you something. Before you came here, I received a call from the hospital telling me to make sure I failed you. He said, but I can't fail you. He said, you're the best student we have. He said, you're the only one who can do all of these things. He said, you have the experience. And I sat in that office. He said, now, if you tell anybody, I will deny it because my job is on the line. And I sat in that room just crying, sobbing. He said, I'll get you out of here. And that man was kind enough to write me a letter of recommendation. Once I complete that 1 year there, I went to Albert Einstein in Philadelphia, where it was such a mixture of people. And I told him when I got to Albert Einstein, I said, don't hire me just so that you can say you have a Black person in your department. And that's where the interview stopped. They said, we want you. We like Black people. And I went on, I stayed at Albert Einstein, graduated top resident in that program. I didn't have the pressure, the racial problem. I didn't have that. Now, not only that, I also had to, I had to do, you've got to understand, when people see a person like me and they say, well, he's a doctor, what? That means, you know, this is evidence there's no racism. That racial experience that I experienced at Hershey, it took me years to get over it. And it's one of the reasons why I stayed in private practice for so long, because I didn't want to deal with it. In a private practice, it was just me, my wife, who was a nurse, and the staff, I had a mixture of white, Filipino, I had all kinds of people working for me. That was my hideout. It took, if it were not for my faith, my family, my children, my wife, it was very difficult for me to get over the anger and the frustration. Now it doesn't matter. And that experience actually, in some ways, changed me a lot, changed me in so many ways. When somebody says they've been discriminated against, I believe it. Even in these big institutions, it happens. And of course, I protected my children. And I made sure that I raised my children in a way where they can stand up for themselves. And, I was able to, my children were my focus. So for so many years, now that my children are grown and they're very successful, it's fine. But racial discrimination, I'm not a person who gets depressed. People who knew me from my childhood, I've always been a very happy person. I come from a very good family. I wasn't making trouble. Racial discrimination is I would say, is the biggest problem that Black folks in America have. And people don't understand the extent, the anger, the frustration that it brings out in people. Now, I'm not angry, I'm not frustrated. In so many ways, I consider myself a very successful person. I've raised children. My children, two of my boys have gone to Ivy Leagues. They've gone to Yale. They've gone to Columbia. They've gone to Cornell. They've done. My kids are done very well. But I make sure all along we talked about race relationship, what to expect, and I just want to end by saying that if I experienced it, I can only imagine what other people are going through. So it's not only confined to the poor African American, it's at every level. And I would say this, I have never experienced the kind of things. In fact, I will tell you one more incident. One night, I was at the Hershey Hospital there, and I was on call. So I was the only person covering the department. And so somewhere around midnight, I get a phone call. I have to give IV chemotherapy to a child who had leukemia. So I get up, put on my coat, I go in there, I walk in there. As soon as I walked in that room, that family, they just jumped. They had never seen a Black person. I don't know why they just jumped. And they said, oh, he's Black. He's Black. And I'm thinking to myself, I've lived in this world. I've never seen such a reaction. I lived in England, never saw it. I went to the Caribbean, I've traveled around the world. I've never, ever, ever seen that reaction. So I'm sitting, so the nurse kind of hushed me out of the room, and I'm like, okay, she said, they don't want you to touch their child because you're Black. And I said, I got it, I understand. And I walk out of there, and I go back to the on-call room, and I'm laying there, and I'm thinking, what just happened? What just happened? 5 minutes later, I get an emergency phone call. Dr. Olusola, pediatric, quick, come, you know. So I run out, I'm thinking, what happened? I thought maybe, well, the nurse tried to give the IV medication, and you know what happened? Because the child has low platelets count, this child started to bleed profusely. The nurse panicked, and she's like, help, help, you know. And I'm thinking, everybody just leave me alone, step back. I put on my gloves, took the tourniquet, put pressure on the bleeding, stopped it, gave the IV, didn't have to stick that child twice. And something awesome just happened in that room. That little girl, in the presence of her family, all these white folks, jumps up, swings her arms around me, and just hugged me and wouldn't let go. And they just stood up like, oh, you hugged a Black person. Oh my God. And so I kind of said, okay, you need to sit down. And I walked out of that room. The next morning, I was getting up to do rounds so I could present the cases to the attendants and to the team. And as I was walking down the hallway of that hospital, that family, they were walking the opposite direction. And they kind of moved against the wall. They kind of moved to the extreme side. And as I walked by, they looked at me, they said, Doctor, we're sorry about last night. We're just not used to your kind. Now, this was 1989 in Pennsylvania. These are memories I can never forget. And I tell people, say, why do you stay in private practice? I stayed in private practice because I didn't want nobody telling me that I'm not good enough. Because I know where I'm coming from. I'm coming from I'm the second generation of physician. My grandfather was a doctor. My dad went to Cambridge University in England. My brother's a doctor. So, but I never experienced this. I knew there was racism, but I never knew people could be so blatant and so hateful. And I wasn't doing anything. It has such a profound effect on me that throughout the rest of my stay in that facility, when I would drive to work, I would stay in my car crying, anticipating what treatment. It was they marginalized me. You understand what I'm saying? They marginalized me. So, you know, so anyway, I'll just leave it there. And so I want to share that because it's, you know, we talk about mental health and physical health. Yeah, I can only imagine if I didn't have the family and my, you know, family support and everything that I needed, I would have broken down. Okay. All right. Thank you.
Dr. O, that was so powerful. That was such a real story and very, very powerful. And I have a comment in the Q&A that I would like to share with you. It is from a community member that is saying, Doctor, we do not have to be a doctor to experience such racial discrimination. It is our skin color, and sometimes the skin color with education. It is sad, exclamation mark. And I have another comment saying it's microaggression behaviors. And then there is another comment saying racial discrimination is real, and it's the highest in all public services. MHD, mental health, DCFS, Department of Children and Family Services, criminal, schools, dental office, social security office, DMV office, Tri-City office, etc. How do we better support the African-American Black people? That's a question. How do we better support African-American and Black people? And that's a question, I guess, to all of you.
Well, let me just start by saying that, number one, I think individually we have to be aware of ourselves, because sometimes a person can be racist and not even realize they're racist. But most people who are racist actually know that they're racist. They know. But I think the first thing we have to do is the awareness. The fact that we're talking about it makes us even more aware. So I would say, you know, and it's important for us to listen. And if we see something, we ought to speak up. If you see somebody being mistreated, you need to speak up. If I see a coworker mistreating a Black person, I'm sorry, I'm gonna speak up. I'm gonna call you to my office and say, hey, you can't do that. And the thing is, I think as a Black person, you get to a point where you have this radar. It's like a it's like a radar. You know somebody is racist within 15, 10, 20 minutes of just being around them. Just the way you can tell. You just pick it up. And so, personally, in terms of working with people at Tri-City, I have not personally experienced it, but that doesn't mean some of our clients have not experienced it. Go ahead.
Yeah, I would add on to what you were saying, but everything that you said is spot on. Is the awareness first, and then naming and addressing it. That provides an affirmation to the person experiencing those racist types of acts and behaviors, be it overt or covert. And so naming it and then addressing it, especially for those of us who work for these institutions, organizations, and systems, we have to do something about it. And if we don't address it and name it, then it's going to continue to permeate and impact the Black community that we work with and serve and that we are of.
And if I may add, we did receive some feedback and we are trying to fix it. And that's why Dr. Alan Lipscomb is going to come and train our entire staff. And his first training begins on Thursday. And he's going to help us to become culturally intelligent, culturally humble, and culturally aware of these discriminations and these issues that various community members of color face. So definitely we are working toward that. So thank you, Dr. Lipscomb, for helping us with it. And we're really looking forward to it and to becoming culturally humble. We can't learn everything. We can't be competent in everything, but we can learn.
For sure.
Yes. Mm-hmm.
Yeah, being able to learn, that equals action, right? So we're learning it in order to bring about changes.
And to be able to say what you said is to be able to tell our colleagues if we feel that there's something happening that is not right, for us to be able to take the person to the side and say, hey, you know what? This didn't feel right to me. Let's talk about this. So to be able to have that difficult conversation with our colleagues and with the other people that we work with, our fellow community members and everybody we come across, definitely.
And by the way, I want to say that sometimes our Black clients might come across as a little bit more hostile, irritated, and that's really based on years of experience. They're bitter. There's an anticipation that you're not going to give me a fair chance. You're not going to deal with me based on, you're not even hearing me. You're not going to, your decision regarding what I'm telling you is not going to be based on what I'm telling you. It's going to be based on the color of my skin. And I think it's important to listen. I think it's important to hear what they're saying. If I can say anything, I think it's just people have to listen. Now, of course, the way Black patients deal with somebody like me, as opposed to a person who's not a person of color, is different. They will talk to me things they would not say. Okay, they will freely talk to me about their racial, the racial stuff that they have felt. And so that's a privilege because they know that I'm going to understand. I'm going to make that connection. Okay, so I think listening and just being able to correct each other and say, hey, I think you're not the way you're handling this. If I find somebody to be racist in their action towards a client, if I would talk to that person, and if that person doesn't listen to me, I'll probably talk to Dr. Teimoori. And maybe he and I can sit down and address it together. Because I just don't have the stomach for it. I really don't. Because I feel where I am right now, as a 62-year-old man who's practiced medicine for 37 years, I just really don't care what people think about me. I don't have to anymore. I'm willing to speak up. And that's where I am. When I went through that experience, I was at the mercy of my supervisors. I felt I had to absorb whatever they had to dish out. I don't have to do that anymore because my kids are grown. They're doing well. They're highly successful. I don't care. So I don't feel like anybody can control me. I'm going to speak up. If I see racial discrimination, it just makes my skin crawl. I will speak up. And you know, somebody may not like it, but I'm going to speak up. You can guarantee that if I see it, someone's going to hear about it. And if that person doesn't change, I'm going to make a lot of noise because I can't stand it, because I know what I felt. I had nobody to stand up for me. I had nobody to reach out to because they were all the same color. I was the only black person in that department. Of course, now I think things have changed over the years, because if you go back there now, they're taking a little bit more, a few more black people, black students, and some of those older generation have left. So,
thank you, Dr. O. There's a question for Dr. Teimoori. How does blood pressure relate to mental health versus medical health? Do you think blood pressure will become a mental health and not a medical health issue?
So, so there is a basically blood pressure. You know, in adult population, almost 85% of the blood pressure that we call it hypertension, we really don't know what's the reason. It's a combination of you know, genetic and also a lot of other factors. So we call it essential hypertension. So sometimes also stress definitely contribute to high blood pressure. You know, high blood pressure over time can damage anywhere that you have vasculature. Basically, one of them is brain. And so if you know, one of the reasons that people get, you know, cognitive changes over time is actually damages that high blood pressure puts in vasculature in the brain. So you can see it that way. And also high blood pressure can cause basically fatigue, can cause symptom of depression over time. It's not directly, but indirectly you don't feel good, so you start to feel down. So it's two basically side of a coin. So it's stress can cause high blood pressure, and high blood pressure over time can damage your central nervous system and cause neuropsychiatric problem, including depression and including cognitive issues. I don't know if I answered the question. If I can clarify if it's needed.
Can I just add a little bit? One of my areas of interest is nutrition, and in actual fact, all the states that I've worked in, I've always done nutritional 7-week series seminar for Black churches and, you know, Latinos. One of the reasons why there's a high incidence of metabolic syndrome within the Black race, besides the fact that they are socioeconomically at a disadvantage and don't have access to a lot of things, don't have jobs, have less education, is the type of food they consume. One of the worst things that you can put in your body is hydrogenated oil. And here's the reason why. The human cells are made of they're made of a bilipid layer, 2 layers of fat. And inside of the cell wall are embedded receptors, which are like your doors and your windows. And those receptors, because they're embedded in the cell wall, anything that affects the cell wall automatically changes the configuration of those receptors. And those receptors are required for your hormones, your immune system to function correctly. You go to most of these Black homes, what are they eating? They're eating food that have a lot of hydrogenated oil. And you can tell hydrogenated oil in your food package because they label soybean vegetable oil. Those are not actually soybean, the real soybean vegetable oil. They're soybean and vegetable oil that have been placed in a gas chamber under high pressure. They have forced hydrogen molecules, and in doing so, they plasticize those oils. Plasticized oil has a purpose. It increases the shelf life of your food. When you consume it over many, many years, it replaces the good fat in your cell wall, and in doing so, it turns off your receptors. So now your hormones and your vitamins, none of those things can communicate with the cells. Your immune system now is out of whack because if the receptors are damaged, it can't communicate. So it becomes, so your endocrine system, your immune system are completely destroyed. And this is one of the reasons why African Americans have a worse prognosis when it comes to the COVID. I was going to actually show you some pictures, but unfortunately, I guess I'm technologically challenged. I couldn't show you. I was going to present some of that. So and one of the things that we don't talk about enough is their nutrition. When you eat a lot of hydrogenated food, your body can't really process it. And what it does is it clogs up the endothelial, the lumen of your arteries. And that's not just in your heart, it's in your brain, throughout your body. So when you do an autopsy on a person who's eaten a lot of hydrogenated oil, what you find when you open up their blood vessel, you see layers of fat. Now, blood is the life of your organs. So what happens is, as the lumens become constricted, the blood flow to the brain decreases. Well, a brain that's losing blood flow is less likely to respond to treatment. Okay, and a lot of these people go on to develop dementia, and the same process is going on in their heart, so they're going to develop heart attacks. And of course, their receptors are turned off. They cannot their insulin can no longer connect with their receptors. So what happens? They get diabetes. So what I try to tell people in the office is, you got to get rid of all the processed food, and you've got to pay attention to what's in your food. Just like when you go to the gas station, typically what you do is you make sure you don't put diesel in an unleaded gas tank. Well, if you put the wrong kind of in your body, it goes along to do a lot of damage.
Thank you, Dr. O. We have two more comments. One is just saying, wow. And the other one is saying, thank you so much for your transparency, Dr. O.
Thank you.
So, yes. So I know we're running over time, and if there are any other questions, I will read those to you. But I wanted to say thank you to all three of you. This has been a great presentation. Sorry, 1 hour went by so fast. Maybe we should have been here longer, but this has been very good. Thank you so much. And Dr. Lipscomb, we look forward to your training. And also, you are the African American Advisory Council would like to hear from you, would like to invite you to our meeting. And so I will get in touch with you. But we've been talking about that, and we'll schedule something. So that's going to happen soon. So thank you so much. And Dr. Teimoori, thank you so much for your slides and the great presentation. And Dr. O, what a great presentation. And we got to know you at a different level. I've been working with you for so long, and got to know you a little different. And you will be, please expect some calls from me for other presentations. So thank you so much. I think I have another question that came up. Let me just read it to you. Somebody said, amazing presentation. And somebody said, thank you, all doctors. This has been very amazing. And yes, that's all the questions I have. Would anybody like to say anything in closing?
Yeah, I just want to say thank you to all the participants. And also, to answer that question about how to support African American in our practice, basically understanding different culture is African American, it's Asian, it's from all over the world, and you come from, like I came from Iran, so I have different culture. It's a process. You need to start learning about different people and understanding their basically actions or behaviors, or what you call it, attitude, and reason behind it, and building that trust. Basically, that's what it takes.
And I have another message from the executive director as well. Said that she's been listening and she wants to say thank you to you all. Her name is Tony Navarro. I think all of you know her. And there's one more question that came up. It is, how does blood pressure medication work for the brain and body? Any of you can take it.
So, so the reason that we use blood pressure medication is usually when somebody is diagnosed with high blood pressure, which is a number system, basically. If it's not severely high, the doctor usually starts you on a diet plan, which is basically low salt. We call it DASH. Basically, it's a diet that it's basically more fruit and vegetable, less meat, and more fresh food, basically, and plus exercise. And if it doesn't help, you don't get to the target, then they start you on medication, which is blood pressure medication. The reason that we are using it is basically they don't cure the high blood pressure, they control it. Because if you have high blood pressure for a long time, again, the same thing, wherever you have vessels like your heart, your kidneys, your eyes, your brain, you can have atherosclerosis, which is the change. Basically, you can have like a stiffening of the arteries, if you want to call it, in layman term. So the way they affect the medication affect the brain, yes, they have side effects sometimes, but overall, the reason that we're using them is to protect body from long-term side effects of high blood pressure, which is basically a silent killer most of the time. And usually people with high blood pressure for years, they don't have any symptoms. So that's basically the control. So it protects the body and the brain against the long-term side effects of high blood pressure.
Thank you, Dr. Teimoori. Another comment, it's saying amazing presentation, and another community member says thank you. And those are all the questions I have and comments that I have tonight. And in the end, I would like to say thank you for coming and doing this amazing presentation, and it'll stay with us for a long time. It was very deep and very powerful, so thank you all.